Okay, I know you're running a bit late. I know you have to leave early, so I'm going to go ahead and get started. When you get on, I'll tell you to come back and take a look at the first few minutes of the discussion here. Code word Tokyo, Tokyo. This week's discussion, again, is to pick one of the end of chapter questions from one of the chapters for this week, which are chapters 8 through 8, 9, 10, 11, and 12. So 8 through 12 we're looking at this week. Today we'll discuss at least a couple of those chapters. And then I will do another recorded session in which I discuss a couple of the others. So I'm going to go ahead and get started. And we're going to go over here to these questions. I want to be sure that this is actually working. Yes, it is. So these are the questions from Chapter 6, which is about physicians. Why do some hospitals cost more than others? Well, basically because they can get away with it. Some hospitals are charity hospitals. Some hospitals are private hospitals. If we look at those, then we have quite a bit of a mess. Why is a hospital bill so hard to understand? Well, why don't they just post a list of prices? Because those prices vary. And those prices that are there, the so-called list price is what we would call it in a restaurant or a retail shop. We look at that, and what we see is numbers. And then when we get our statement from our insurer, we find out that that bill has absolutely nothing to do with what we're actually paying. And what we're actually paying is a negotiated price. What that is an excuse to really keep their prices artificially inflated so that they can talk about the so-called cost of charity patients. It's a scam, in my opinion. It's all an accounting trick. If the insurance companies can get a negotiated price that's 60 to 70% reduced versus, or even 80% reduced versus what the list price is, then they can all do that. But that's my opinion. Why have hospital costs continued to increase faster than other healthcare costs? Well, because hospitals are highly technical facilities that require a lot of people. 75% of their budget is staff. The hospital itself is an expensive thing to build and to maintain. Large hospitals expensive because they suffer from diseconomies of scale. We all know about the phrase of economy of scale. The more of something, the less it costs. There's the reverse of that. Sometimes the more of something, the more it costs. In this case, we're talking about highly technologically based treatments, specialized surgical procedures, etc. That's what they mean here. Or because they admit the most difficult to treat patients. Basically, nobody goes into the hospital because they want to stay at a nice hotel. As much as possible, we try to treat people outside the hospital. The question number 5 about buying a new MRI machine if it expects the thing to be busy only half the time, and the hospital that's nearby already has such a machine. There are lots of reasons for that. A lot of it has to do with we do not have a real public policy issue about the presence of these machines, and we have very few controls. There is no real need for every hospital to have an expensive machine like an MRI or a PET scan or any of that stuff, except that there are times when, and this is one of the excuses, there are times when we really do need to get something done right now. We cannot afford to transport patients across town for time purposes. So there's a lot of reasons that they use, but there is good evidence that we have far too much of this around than we need. Will computers and other new technology improve efficiency and hence reduce costs, or will they improve quality and raise costs? That's really yet to be seen. Computer technology clearly has made things a lot more efficient. And efficiency often is associated actually with an increase in quality. Do they raise costs? Yeah, these systems are expensive. In the long run, though, do they lower costs? Possibly. Okay. Regulation, does it cut costs or cut competition? I think that depends on what regulation you're talking about. So we'll get into that too. Read the chapter. And then let's go to chapter 7. Medical education. We'll go to those questions. Who controls the supply of physicians, government, or American Medical Association? Well, the government really doesn't. The American Medical Association was actually formed to regulate hospitals. And as a result, they have a lot to say about what hospitals are, or what they regulate medical schools, rather, excuse me. That was the original reason following the Flexner report at the end of the 19th, beginning of the 20th century. That was the reason for the formation of the AMA. It was to do that. We also have the American Hospital Association and a couple of other organizations that accredit these things. So the AMA was formed to make sure that we had good, solid education, medical education in place. Originally, physicians could go and basically it was like a guild. You did an apprenticeship with an existing physician and then hung out your shingle. No problem. The thing to do is that with that is to remember that like anything else, it's grown up. We also have changed so much and learned so much. But the AMA was formed to basically to make sure that they provided some standards for the education of physicians. That grew into more of a lobbying organization and an organization that has done as much to try and restrict the supply of doctors as possible. The actual licensure of physicians is done at the state level, and licensure certainly is a way of controlling that supply of physicians. The licensure process is really designed to be sure that we have well-trained people. The problem is that unlike almost every other profession that you have to be licensed in, the vast majority of people entering medical school graduate. The vast majority of those pass their exams and are practicing physicians. Now, there's a good reason for that. When your admission standards are such that most of the people coming in are very well qualified, very well educated to come in, to begin to go into medical school, then that's not a terribly big shock. However, the licensure procedure. However, the control really comes from the number of people who actually graduate. In 2017, your book is dated back a ways. In 2017, right now, 2019, we have 144 MD granting institutions in the United States and 35 Doctor of Osteopathy granting institutions. Doctors of Osteopathy make up a small percentage, about 5%, I think, of the physicians, but they are often found in general practice settings. They're very rarely specialists of any sort, and they are trained just as well as MDs for those settings. In 2017, there were a little over 19,250 MD graduates from U.S. medical schools and about 6,500 DO grads. This data comes from the Kaiser Family Foundation, by the way, who monitor these things. So we do, in a way, the AMA has a lot of control over that, over the supply of physicians, by their ability to accredit and accept medical schools. We have had a high of, I think, 175 medical schools at one point in this nation. Back in in 2013 or 2012, actually, the statistics out of your textbook, there were 127 medical schools. Well, since then, we've added increased that by about 10%. We do need to have a lot of different physicians. The medical profession does have a lot to do with the number of doctors. Are doctors more or less productive than they were 20 years ago? Technology and education has done that, but I'm not sure what productive means for a doctor. Patients in Boston, why do they undergo more surgeries than patients in San Francisco? This is because there really is not a standardized agreement on just what the physician's practice ought to be and what standards ought to be. So in different parts of the country, you may have, for instance, I think in the text it talks about a large number of or tonsillectomies in some parts of the nation, and very much fewer in other parts of the nation. You have to understand that this is really a reflection that there isn't really an objective, well-defined approach to medicine. It all depends on local practice. Can medical groups advertise to attract more patients and increase market power? Well, the answer is yes, they can advertise. You see it all the time. Advertising is many, many things. Are bigger practices more efficient? Bigger practices can potentially be more responsive to patient needs. Recently, we needed to take my mother-in-law to see her doctor. Her doctor had no openings in her schedule, so we went to see one of her associated nurse practitioners, physician's assistant. We get in there, the physician's assistant looks at the issue, and then the doctor made a time in her schedule to come in and actually take a look as well. So can they be more efficient? Yes, I think we're very happy with that kind of result. Price discrimination, is that legal? Well, there are arguments all over the place. But Most of us accept that there are people who cannot afford medical care, and if we pay more through our insurance so that other people can get care, most of us will say that's okay. And partly because since we have insurance instead of actually direct pay, we don't actually pay our doctors. The copay is more a case of a disincentive to just go for every sniffle than a real payment to the doctor. So we really have no incentive to worry about that. And most of us would agree that if our insurance payment is a little higher every month, so that people who have no way of paying for their medical care can get some basic level of care, most of us are going to say that's a fair trade-off. Americans are incredibly charitable and generous. And so for the most part. And so we will sit there and put up with that sort of thing. There are lots of ways that doctors give discounts on fees. I mean, we look at insurance payments, the issue for insurance payments is that the insurance companies have the system we have now. The insurance companies have negotiated those prices. Doctors are paid X amount for a visit. Specialists are paid more. Surgeons get paid more. Hospitals get paid, what they get paid. So they're negotiated prices. So we do have basically a list price for medical services that all of our people have. That list price is as much fiction as anything else. However, it's one of the reasons that we have such a large bill, because it does appear ultimately on certain kinds of transactions, especially people who have no insurance and are being billed the full amount. Why and how do they give those discounts? Well, most of it is sometimes they will just do charity service. That used to be the way hospitals ran when they first started in this country and on this continent, and actually in Europe, is the doctors just practiced there as charity, as a contribution to the society. Do physicians trade patients? Sure, they do. I mean, obviously, we have referrals for specialists. Obviously, there are times when you call in extra people. So, yeah, payments between doctors for referrals, legal, ethical, or efficient. Well, legal probably, because lawyers do it all the time. If as a lawyer, you refer a case to a colleague that you either don't want to or really don't feel you can take, then you get a part of their fee. They pay you for it. Are they efficient? Probably not. Ethical? Well, that's a good question. I don't think I want to get into it. Chiropractors a substitute? No. They're a complement. They have a different approach. Spinal manipulation is what chiropractors do. Chiropractors have very limited prescribing rights for things like pain medications. They can do X-rays, but they cannot diagnose infectious disease, say, or anything else. And if they see a major problem, if they suspect a really major problem that chiropractic isn't capable of dealing with, they simply refer you on to other people. Chiropractors can't do surgery. If they look at someone who comes in with a chiropractic or thinks they have a problem, and the problem is one that needs to be surgically addressed, they will always refer you to the appropriate specialist. Okay. Set standards of practice to guide clinical decisions. Well, the medical associations do, and there are many medical associations. There is not just the AMA. Every specialty has its association: the American Heart Association, the American Society for Clinical Oncology, the American endocrinology societies, and so forth. So there's a lot there to be said for that. So those are the kinds of questions. If we look down here, right, if we look this year for them was 2012, because I think that's when this textbook was written, or this edition was written. So we have lots of issues in this particular chapter. So we're not going to go into all these details. You need to actually get through the chapter. They're not difficult reads, and you can skip a lot of stuff. This information about tuition is totally outdated. We know it's expensive. We know that this Flexner report, it's 1910, so it was changed the way medical education was structured in the United States. So let's go on to chapter 8, and then I'll ask a couple of questions and cut this off. Chapter 8 is about hospitals. Hospitals, how do they get paid? What do they pay for? Does it make a difference? Why don't philanthropists donate? Who pays for medical research? Cost shifting help the poor or the rich? Reimbursement increase employment, or does it drive up costs? Who owns a nonprofit hospital? And are they charitable institutions or instruments of corporate control? Hospitals are a business. They have to stay in business. There are several different kinds of hospitals. There are big public hospitals. There are private hospitals. The first hospital in the United States was founded in 1751 in Philadelphia, the Philadelphia Hospital, or the Pennsylvania Hospital. It still is in existence today. And it was mainly funded by charitable donations, and dealt with mainly sick and poor with disabilities, although there were some, of course, paying patients that were there. How do they get paid right now, and what do they pay for? Those are two very interesting questions, and very convoluted questions. They are paid in a lot of different ways. There is some philanthropy, some grants. They have payment from various sources. 95% of hospital revenues do come from third-party insurance, with 51% of that being governmental. So we've got most of that, a little over half of the payments come from government. The thing about the way that happens, if you're not paying, then you don't cost shop. You don't go around from one hospital to the other. What you do is you look for a hospital that's going to provide you the best care you can get. We had that again a couple of years ago with my mother-in-law when she broke her femur. We started talking to our nursing friends in the area, and we knew that she was going to have to go to a rehab hospital. We wanted to know what was the best one. And the one that was consistently recommended to us was the one over on Highway 34 here at I-25. The Northern Colorado Rehabilitation Hospital, and a privately owned hospital, it's physician owned, but we were told repeatedly that it was the best place to go from our friends in the medical profession. Turned out to be a very good place, a good staff, lots of people. It's a rehab hospital, so they have a huge physical therapy department. They have their own internal pharmacy. and they have they're very much oriented toward the patient. We found it to be a very, very good organization. Not to say that any others aren't. It's just that this is the one we have experience with. But the government, when the money started coming in, when insurance came in, and when Medicare went in, remember that Medicare recipients consume a hugely disproportionate share of the medical resources, and time and medical costs are largely taken up by people on Medicare. Medicaid is is a little bit behind that, well, considerably behind that, really. But again, that's a government program. So it's actually a well-run government program. I know a lot of people will rail about it, but it's actually fairly well run. But the control of those costs are done through negotiated prices, reimbursement levels, through a very complicated thing. You've heard of the diagnostically related group payments, and we've already talked about the fact that all of the charges that they have are negotiated with insurance providers. There's very little negotiation with Medicare. The government decides what it's going to pay, period. And that can be appealed. It can be a lot of things. So why don't philanthropists donate as much as they used to? They don't need to. Philanthropy comes in. There are philanthropists who will actually do things. If you go down to UCH down in Denver at I-225 in Colfax, you'll see the Anschutz Pavilion, where the Anschutz family actually donated the building. Well, or donated the costs of building most of that pavilion, and several there. That's where a lot of the philanthropy comes these days. So it's not an ongoing donation as much as a specified grant for a specific purpose. Who pays for medical research? That's a good question. It's a big argument. A lot of it's paid for by the government through the National Institutes of Health. But a lot of it's also paid for by pharmaceutical companies. Basic medical research is almost all government supported through grants to researchers at hospitals and medical schools and associated researchers in the regular schools who work with the medical side of their university. I have dealt a lot with university researchers looking to develop potential drugs, and they all partner up with people at their associated medical schools. We do that here in Colorado. There's a lot of conversation back and forth between basic science groups at the universities and the hospital system and their employed researchers. There are a number of people who work in the hospital that actually do basic research. So they are actually employees of the hospital system. Now, that works for the big academic hospitals, the big teaching hospitals, because we need those people there. For the most part, your local hospital, and I'm thinking about things like MCR, are not going to be supporting a lot of direct basic research. So that's all done in a different setting. Does cost shifting help the poor or the rich? It depends on what you mean by help. If we shift costs to wealthier people or off on others, then is that helping the poor get care? I think the answer to that is yes. Can the rich afford it? Well, if they're rich, they can. It depends on how you define rich, doesn't it? Many of us in this society at the lower economic levels are better off than people in India. So we are rich by comparison, but that, you know, it's all context driven, rich in terms of the context of being in the United States society. Does reimbursement increase employment? The answer to that is going to be very complex. And does it drive up costs? Well, if you are being reimbursed for your costs, then there is little impetus to reduce those costs. So does it drive up costs? Well, short answer to that is it probably does. It definitely doesn't provide an impetus to drive them down. Who owns a nonprofit hospital? Well, there's an interesting question too. What do you mean by nonprofit? There's a difference between nonprofit or not-for-profit and charitable. The term nonprofit or not-for-profit is a tax designation. They can make a profit. Many of them do. Others do not. There are public hospitals that are owned by public institutions. UCH, the hospital down in Denver, UCH is owned by the university. Probably set up somewhat structurally different, so that there's a funny relationship there, but nonetheless, it is owned by the university. Publicly funded hospitals, hospitals down in Denver are owned theoretically by local governments. The idea that that hospitals are owned. There are hospital chains, and there's some argument about whether or not these for-profit chains are good, are really do work, and are providing the proper services. There is, to some extent, an economy of scale, and there are other diseconomies. When you get into large hospital chains, they have a lot of buying power and can reduce their costs. I don't know that those costs are ever passed on. The idea of who owns a nonprofit hospital, many hospitals are incorporated as tax in terms of the tax code for as not-for-profit operations. All that means, from a tax code standpoint, is that the so-called profits are put back into the institution rather than given to shareholders. So who are the shareholders? Generally speaking, when something is incorporated, there is someone or some entity who is the shareholder of that organization. For a lot of large public hospitals, that shareholder is going to be the local government. And it will be actually run by a board of governors or trustees, depending on the organization, that often serve for no reimbursement on their own, for no salary or reward other than being involved in the charitable work of a hospital. So are hospitals charitable institutions or instruments of corporate control? Yes, is the answer, really. They are charitable institutions because all hospitals are required to take patients whether they can pay or not. Are they instruments of corporate control? Well, yeah. If you look at the big hospital corporations, Hospital Corporation of America and others, those are large corporations. And they are obviously, since hospital building actually is going up quite a bit, you actually have the possibility of looking at this. There is some belief that hospitals would turn away people who can't pay, and that belief has some support. We call that cream skimming. In other words, only taking the patients that we're going to make the most profit on, turning away those that are going to actually end up with us spending more money on than is going to come in. The costs of this have been occasional lawsuits and some real hits. Other attempts to reduce costs include early discharge. Hospitals would do that in order to theoretically get more money because of the DRG payments and because of Medicare payments, until it was seen that these patients would bounce back in, and now there's a mechanism for punishing hospitals that have bounce back. In other words, their patients are sent home, but they're too ill to go home, so they end up coming back to the hospital within a matter of a couple of days for the same condition, and they should not have been sent home in the first place. So the other part of that is that you'll have to understand that they are constrained by the need to actually make money. And the reason that I say that is that they have to be able to pay their bills. 75% of their costs are their staff, and you can't just sort of say, okay, we're going to cut staff, because then you're in trouble. One of the biggest problems with nursing homes is exactly that. We're not talking about nursing homes here, but there will be a chapter on long-term care facilities later. But one of the biggest problems is that they try to increase profit by cutting staff, and that really cuts into the service that they can give to the patients. The individuals working want to provide that service, but the corporate managers are not interested in the payment. So we do have a lot of different things going on. So the question about charitable institutions or instruments of corporate control depends on the hospital. We do have charity hospitals still in this country. We do have hospitals that will take whoever walks in the door and not worry about it. And in fact, physicians, nurses, etc., the people who actually deliver the care really don't care. They have nothing to do with that. All they want to do is deliver that care. So the development of the modern hospital did begin in this country in the 20th century, and it became the biggest user of healthcare funds, and now we're looking at what we're calling health systems. And we look at what's going on. Hospitals have associated clinics and associated home health services, and often many sites. If you take a look at the Exempla organization, you've got St. Joseph's up in Louisville or Lafayette. You've got Lutheran down in Wheat Ridge. So you've got a number, and a couple of other hospitals around, they've consolidated. There is a reason for that, but is it good? Well, we'll have to find out, because we're still experimenting really with what is the best structure for delivering healthcare at an affordable price. Let's see if I have, yeah, I just wanted to bring this up. Let's do a new share here. Let's do this one. Okay. This is something that that I found. It was written back in February. It's an interesting article. Federal government says that Americans spent $3.65 trillion on healthcare in 2018. This represents a huge increase over 2017, 4.4%. We expect the annual growth rate for healthcare costs in the to increase at a rate of 5.5% for another 10 years, basically. Current inflation rate is 1.6, and wage growth actually has stayed below 4% for a while. So we're expecting by late in the next decade that healthcare will be over 19% of the entire gross domestic product. So this represents $11,212 per person. 59% of the spending going to hospitals, doctors, and clinical services. Prescription drug spending was up 3.3%, but mostly due to higher prices. What we don't know is what percentage from this. I don't have the full study on this, but the fact is that we have a larger amount than the GDPs of major countries, countries that are considered major in terms of size: Brazil, the UK, Mexico, Spain, and Canada. So we are really looking at increasing difficulty affording medical care in the United States, since the increases are vastly outstripping both inflation and wage growth. So the real issue is how much money are we spending and why. A lot of that is, notice that here 59% goes to hospitals, doctors, and clinical services. Well, okay, doctors get paid separately. Why do we say hospitals and doctors? Because doctors don't actually work for hospitals. They have practice rights. They bill separately. Surgeons are billed, use the operating suite, so we pay for the use of the suite. We pay for the hospital employees who actually work there, which would be some of the nurses, some of the surgical techs, and some of the other staff. But a lot of times, even the OR nurses are people who are contracted from the outside. I have a friend who actually has a company down in Denver that is an OR nurse company, and that's what she does. She was an OR nurse for years, and she now has people working for her, and she staffs these ORs. All of these are billed differently. Clinical services, if you have a blood sample taken, sometimes the hospital will have its own analytical staff, their own laboratory, but a lot of times, if it's taken by Quest, it goes to a Quest analysis center. So we pay for those services as well. Specialized testing, therapy services are there. So we have a tremendous force that's driving our healthcare. Let's go back to here. Okay. So I'm going to let this go now. You said that you could be here till 8:30, and then you're going to have to again, give me the code word, Tokyo, Tokyo, for listening to this. I will be recording it and getting it posted, and I will send you an email right away to let you know that I'm in the process of getting this posted. So I hope things are going well with your appointment, and I will be recording another session. You can always contact me by email, and if we need to have a short session face-to-face, we'll do that. So I hope things are going well, Crystal, and I'm sorry you couldn't be here this morning. So I'm going to end this now and talk to you later.